Hello. It's good to see everybody. We pulled a switch here. Our great executive director, Zinat Rahman, was going to make this introduction, but I executed on my director's prerogative and took that role from her because I have such a high regard for our speaker today. I got to know Dr. Wen when we did a podcast, one of my Axe Files podcasts, sometime last year, I guess. She had just written this wonderful book, Lifeline, A Doctor's Journey in the Fight for Public Health, which I recommend to everyone. And it was a revelation about public health, but also about her and her extraordinary life. You'll hear more about that, I'm sure, in a second. But we're really pleased to welcome you here. And COVID was the hinge, but there's so many things about public health that COVID exposed that you've dealt with as Public Health Commissioner in Baltimore. So it's really timely and great to have you here. I want to say that tonight I'll be moderating a discussion on the legacy over at the Rubenstein Forum on the legacy of the late Mayor Harold Washington, who is really a huge figure in the history of our city and the history of black politics in America. It was his 100th birthday a couple of weeks ago, and that's the occasion for this event. Tomorrow, the IOP will host former Senator Al Franken for an evening of comedy. He's on tour right now around the country. And that will take place here on the third floor of Ida Noyes, in the theater, beginning at 5:30 p.m. And on May 4th, Secretary Pete Buttigieg, former mayor of South Bend, former presidential candidate, will participate in a student-led discussion that will take place at the Rubenstein Forum. So we hope you'll come back for all of those. After today's moderated discussion, we will open the floor to take questions for you in the audience. For you in the audience. Sorry, I'm just reading here. For you in the audience. Please stay in your seat, raise your hand, and wait for our moderator to call on you. Masks are optional for students when asking questions per the university's latest guidelines. As usual, we give priority for the first questions to be asked by our students. Make sure your phones are silent. Make sure your questions are questions. And we'll now hear a formal introduction of our speaker and moderator from Bridget Patterson, a fourth-year student in the college studying public policy, and who has been involved with the IOP, for which we're grateful. Did I say you were from Atlanta, Georgia? From Atlanta, Georgia. So please join me in welcoming Bridget. Oh.
Okay, can you, okay, yes. I'm not a very loud person. So hi, welcome to today's IOP Speaker Series event. Today we're having a conversation with Dr. Wen. My name's Bridget Patterson, and as David said, I'm a fourth-year public policy major in the college, and I'm really involved in the IOP through USHI votes. But I'm also a public health total nerd, and so I was super excited to introduce Dr. Wen. Dr. Wen has a really impressive background. She's currently a practicing emergency physician and professor of health policy at George Washington University. She also served as Baltimore's health commissioner from 2014 to 2018 and has written 2 critically acclaimed books, one on patient advocacy, When Doctors Don't Listen, How to Avoid Misdiagnoses and Unnecessary Tests, and her latest is called Lifelines, A Doctor's Journey in the Fight for Public Health. She's also actively a contributing columnist for the Washington Post, publishing twice a week about important public health issues. Dr. Wen is here today to talk about her journey of her career in public health and the connections between health and a variety of social issues. The conversation will also touch on Dr. Wen's latest thoughts about the ongoing COVID-19 pandemic. Moderating today's conversation is Kristen Schorsch, a WBEZ reporter who covers public health and Cook County government. Please give a warm welcome to Dr. Wen and Kristen.
Hi, thanks so much. Can you hear me okay, or do I need to bring this closer? Can you hear me okay? Yeah, in the back. Okay. Yeah, thank you so much. I'm so excited to have this conversation. I'm going to start out with talking about, asking about your book, Dr. Wen.
Mm-hmm.
I don't know if you all have read it, Lifelines. It's incredibly fascinating. It documents your journey moving to the States from China as a young girl. And, you go through cycles of extreme poverty. You're homeless at times. You experience the broken healthcare system in the U.S. There are so many moments that shape what you become, so I wanted to go through some of those in the beginning.
Mm-hmm.
Right off the bat, there's this incredible scene with your neighbor, Tony, that is so moving. He's this young boy, third grade, I believe, and was suffering an asthma attack. And you were a kid, not much older than Tony, right? And you watched this happen, and he died right there. I'm wondering how much that moment, shaped what you become and how much Tony stays with you every day, because it seems like there's a reason for why you led off with that story.
Right, and first of all, Kristen, thank you for moderating, and I also wanted to thank Bridget for the kind introduction, and of course David and your entire team here at IOP for inviting me. I actually have had discussions with David. He mentioned about the X-Files in our conversation on this podcast, and I thought a lot about, in reflection, why I wrote Lifelines as I did, as in I wanted a lot of it to cover the experience of leading Baltimore's health department. But just like with all of us, we don't come to leadership positions as that person in all of our professional accomplishments and educational achievements. We come to it with our own lived experiences. And I wanted to share that story of how I was growing up in a way that I think maybe people don't always know, by looking at, where you went to medical school, or where did you do your residency training, and where did you, where you worked, but who was I as a child? Mm-hmm. So maybe starting from even before that particular scene. I was born in China. I came to the U.S. with my parents just before I turned 8. And we came from Shanghai, which is in the news a lot these days for other reasons that we can talk about later, but we came from a city of 20-some million people to a little town in the mountains of Utah. And actually, there's an interesting connection to Chicago here that I'll mention. I don't think was in the book, so I'll mention this. So there were very few ways for people to leave China at that time. And one of the ways was for my mother to come as a graduate student. And so she applied to graduate programs and was accepted to 2. One of them was Utah State University in Logan, Utah, in the mountains between Utah and Idaho. And the other was University of Illinois in Chicago. And so this is, 1989, 1990. And so before, Google or whatever, right? Alta Vista, whatever we had as search engines. And my mother asked her professor. She said, I have these 2 choices. Where should I go? And her professor said, well, I don't know about these institutions, but Utah is where you want to be. And so I think back because we could have had our start in University of Illinois, Chicago, and who knows, maybe I would have joined you sooner here at U of C, but nevertheless, we ended up in Utah. And so we moved from Utah to LA, and it was actually in that time that we experienced a lot of these difficulties. I mean, my parents, despite being professionals in China, I think as many immigrants go through, ended up taking very different jobs here. My mother went from being an academic and teaching to cleaning hotel rooms and working in a video store until she was able to get her teaching certificate in order to teach. She became eventually a second-grade teacher in Los Angeles. And then my father was an engineer in China, washed dishes in a restaurant, delivered newspapers. I think they did what they needed to so that I could fulfill my dreams later, to give me and then eventually my younger sister a chance to fulfill our dreams. But I set this up as context because we were living at that time in an apartment building where one of our neighbors was this boy who I think was about 8 years old, and I think I was about 10. Mm-hmm. And I had asthma growing up. I actually had severe asthma, and so understood the sensation of breathlessness. Did any of you also have asthma, or do any of you have asthma too? Maybe some of you? I think it's quite common in children and in adults as well, but those of you who've had asthma or seen somebody with an asthma attack, there is this sense that you can take breaths in, but you can't fully breathe out. And then it's a really frightening feeling when you take a breath in and not know whether that's your last breath. And I knew what that felt like. And so I heard this boy's grandmother call for help. And I went to see him, and he was in this chair, really rigid in his chair, taking these breaths and not knowing whether this was going to be his last. And so I recognized that sensation. I remember giving him my inhaler because I saw that his inhaler was empty. And he used the inhaler, but it didn't work. I had been hospitalized multiple times because of my asthma, and I said to his grandmother, please, you need to call for help. And she said she couldn't because she was afraid of immigration officials coming because the family was undocumented. And I just remember that by the time that they eventually called for help, it was too late. And this boy had literally died in front of my eyes. And you can imagine that as a 10-year-old, that memory was very much seared in my mind. And I had a subsequent conversation with my mother that night where essentially she said to me, in this country, in this society that we live in, people's lives are not valued the same. I mean, obviously it should be, but it's not. And I don't know that that was the moment when I said I need to go into medicine, but it definitely was one of the moments that spoke to me so much about what I wanted to do in my life, that I did not ever want to be in a position where I had to turn somebody away because they couldn't pay for healthcare, because of where they came from, because of what immigration status they have, what insurance they had. And so that's why this is a really long answer. I promise the rest of my answers are not going to be this long.
No, it's good context. I'm glad you set it up because you just need to read this book. You need to read this opener. It's shocking and it's incredibly sad, but I think it speaks to, it's foreshadowing in a lot of ways who you become and what you become and why. And fast forwarding a little bit, another example I think of this is with your mom. And you write about how when she was diagnosed with breast cancer, that diagnosis was delayed. It was not on time. It should have been earlier. And that, she wouldn't ask the doctors perhaps questions. She didn't feel that she could. And that really, from that standpoint, you started to go with appointments and you became this fierce advocate for patient care when you became a doctor. Mm-hmm. So I'm just wondering, how has that shaped your relationship with patients? I mean, you think about what happened with your mom and you watched some of that, you witnessed some of that, right? That lack of kind of communication. So I'm wondering if you could speak to that, like just day to day, like how you work with patients to make sure they're centered in their care. But also in terms of the policies that you've chosen to highlight and change or gone after and changed, because I feel like that's probably all related.
Yeah, so I was a second-year medical student at WashU in St. Louis when my mother was misdiagnosed and diagnosed basically a year later with what turned out to be metastatic breast cancer. And I remember so vividly, actually, my mother was one of those people who never complained about anything. She took care of everybody else around her and never thought about herself. She took care of I have a little sister too who's nearly 12 years younger than me. Her birthday is in 2 days, so I'm sure happy birthday then. But she took care of, her parents and my father and my sister and me, and she never thought about I never ever heard her talk about how tired she was or how she needed care. So one day she called me, and I remember this very well. She was in LA and working as a second grade teacher, and I was a medical student, and she called me and said, there's something wrong. She said, I went to my doctor. I don't know how to explain it. My doctor keeps on saying that I have a cold, but there's something wrong. And she couldn't quite pinpoint it. And I kept on asking her, but what are you feeling? What is it? And what I eventually got out was that she was just really tired. She was short of breath. It was to the point that she was having trouble climbing stairs. And this is someone who was totally, very high functioning before. And so there was something wrong. But her doctor initially said, well, we're going to do some lab work. And then the lab work must have been fine. And then the doctor said, well, I think you're depressed. So gave her antidepressants. She went to see another doctor who saw that she was on antidepressants and diagnosed her with anxiety. And I think and I remember going to the doctor with her during one of these appointments, and while we were in the waiting room, she said to me, don't speak up. She said to me, don't ask questions. It was almost like she didn't watch this, but it was like Elaine in Seinfeld. She was afraid of getting fired by her doctor. And she thought, and I think a lot of people, whether it's because of age or cultural background or something else, they're really afraid of speaking up and asking questions, thinking that somehow there's going to be retaliation. And I think about this every day because that was maybe 4 or 5 months before my mother's eventual diagnosis. And I think back to what might have happened if I had actually spoken up and been her advocate at that time. And so I say this because, my mother fought her cancer for the next 8 years. And I was her caregiver for 8 years. That completely coincided with my medical school and residency. She ended up dying when I was a resident in emergency medicine. And so I saw how much we in medicine were trying to do the right thing. I worked with amazing people who were trying their best every day. I mean, there was not a single nurse or pharmacist or patient care tech or anyone I ever worked with who was trying to do wrong by patients, right? Nobody was trying to do misdiagnosis, or nobody was trying to not listen to their patients, but somehow that disconnect was there. And I remember another incident, I don't think this was in the book either, so I'll mention this now. In residency, I got involved with a committee at Brigham and Women's Hospital in Boston, one of the first, I think, of its kind. At the time, this was, now it's commonplace, but at that time, this was like 2011, 2012 or something like that. And we were starting a committee where we had patient representatives. God forbid, right? I mean, who knew that you should have patients representing patient care? But we had patients sit on this committee to help us with identifying ways to improve. And we had a complaint by a patient's wife. And this complaint went something like this. This patient came in. I'm going to, on purpose, mix up some of the details so it's not identifiable, and it won't be. But this is a patient, let's say, in his 50s, who was having lunch nearby, experienced an elephant sitting on his chest, severe chest pain, left-sided, radiating to his jaw, right? Classic heart attack symptoms. And so came into the emergency department. Emergency department was busy, but the triage nurse saw this patient, walking in, saying, left-sided chest pain, elephant on his chest. Immediately, within, less than 10 minutes, got him into a room, had all the electrodes placed on, got an EKG done, showed that he was having an acute heart attack. Within 25 minutes or 30 minutes, was up in the cath lab, getting an interventional cardiology that cleared up the blockage in his artery. Within a week, he was discharged from the hospital and doing just fine. I mean, from a medical point of view, this was exceptional care, right? Door to balloon time, everything was exceptional. His wife complained, and we were reviewing this complaint, and her complaint sounded something like this. She brought him in. She was not told where, she was told to wait in the waiting room. Nobody came to say hello to her. Eventually, she was told that he was in the cardiac ICU, and she had no idea why. He was eventually discharged, and the discharge instructions said that he had a heart attack, and she said, until then, nobody told me that he had a heart attack. You can see that what was lost was not the patient care. It was something, there was a disconnect that exists in the communication. And I think that, to answer your question, that is what I've really committed my career to as well. And Bridget had mentioned the first book that I wrote was about how to bridge that disconnect between what it is that patients are experiencing and what the medical system is trying to do, honoring that both sides are trying to do right, but what is being lost in that process.
I remember that from your book.
Oh,
I don't think the complaint.
now I don't remember if I.
No, it's okay.
I don't remember what I wrote in the book and what I didn't.
Reader, so it's fine.
Okay.
I don't think the complaint file though was in that. But,
Okay.
But you're describing the example, and
Yes.
and yes, I mean, healthcare is already so confusing and tough to navigate. So imagine sitting there as the wife, not understanding what's happening to her husband, right?
Right.
So I want to segue a little bit into your time running the Baltimore Public Health Department. So you wrote a few times in your book, "Don't let perfect be the enemy of the good."
Mm-hmm.
So I was wondering if you could explain that, what you mean by that, but also how basically you went around barriers to tackle mental health addiction that was really, really tough happening in Baltimore at the time.
Yeah. I think there's often a problem in public health of decision paralysis. And I don't think this is just in public health. I think this is really in any setting where the problems are really big. And in public health, everything is by definition related to each other, right? I mean, I used to, when I first started in my job in Baltimore, I used to show a map of the city. And the map would be coded by color. And it would look at, overdose rates and cardiovascular deaths and life expectancy and so forth. And actually, I stopped showing that map because it almost didn't matter what was in the legend. As in, the same areas that had the highest poverty, the lowest educational attainment, the highest rates of incarceration, the highest rates of violent crime, also had the lowest rates of, or the highest rates of cardiovascular death or overdose death or lowest life expectancy, right? Everything was correlated with each other. And by definition, public health is about housing and education and access to food and all these things. And I think sometimes there's a tendency then to be like, well, if I have to fix everything to fix something, where do I even start? And so my philosophy about this was, well, you got to start somewhere. And I'll give you some examples of what we did. So one of the programs that I was very proud of in the city that's still going on strong now is called Be More for Healthy Babies. And this is a program that involves now over 150 public and private partners that was centered on one goal, which is to reduce infant mortality in our city. Now, infant mortality, you can come up with 50 different causes for why there's high infant mortality in Baltimore. I mean, back, I think this was now in 2009, Baltimore had one of the worst infant mortality rates in the country. It was behind North Korea. And a black baby born in Baltimore at that time was 5 times more likely to die than a white baby in their first year of life. Okay, so huge disparities, huge inequities, and huge problems that, again, you could trace to so many things. But we said, and committed to this and said, this is a solvable problem. And we're not, we're going to address this all at once, asking the partners to do what they can from their vantage point. And so what we did included educating on the ABCs of safe sleep, right? So alone on the back in a crib, don't smoke, no exceptions. We provided free cribs to families that couldn't access them, housing resources, set up a system for every pregnant woman on Medicaid was then stratified based on levels of care, levels of need. And so a pregnant patient might receive a social worker or might receive a nurse to do home visiting if this person ended up having mental health as well as physical health issues. Or they would also have postpartum visits. And some of these home visitors, for example, on these postpartum visits would find that there was lead paint all around the house. And so it was not just helping that baby, but also helping the entire family. And so as a result of all of these interventions and all of these partnerships, within 7 years, we reduced infant mortality in our city by 38%. And very critically, because we also said we need to embed equity metrics. It's not, I think sometimes when we discuss equity, there is almost a zero-sum mentality of you got to take years of life from one group and to add it to another, right? Which is, we're trying to say that's not the case, that it's all boats rise if you focus on the most vulnerable. And so we said, if we also commit to an equity metric and an overall metric, that's how we're going to measure success. And so we also, in that same period of time, when overall reduced infant mortality by 38%, we closed the disparity between black and white infant mortality by more than 50% in that same time period. So that's one example, and I'll give you another one because you mentioned addiction and mental health. When I first started in Baltimore, this is at the end of 2014, we were having then, and still have now, a major problem around fentanyl. And record numbers of people dying from opioid overdose, but in particular due to fentanyl. I knew that what we needed to do overall was to increase treatment for addiction. But I also knew, and this actually is more David's specialty working in politics than mine, but I also knew that politically, if I had come in and said, what we need to do is to start more addiction treatment, I would have lost any political capital before I even started, because what everybody would have heard is methadone clinics. People equated in Baltimore treatment with methadone clinics. And with methadone clinics, there are all these NIMBY issues, right? The not in my backyard issues. And in our city, it was so bad that NIMBY became banana. Don't build anything near anything that's near anything, right? Everybody knew that they needed, if you just said, we want treatment, they were like, great, but don't have that in my neighborhood. And so so I made the calculation at that time, I want to focus on this overall. But we need to get enough political capital and enough buy-in in order to do this And so we need to focus on something else first that was more politically palatable. And so what we specifically decided, and again, it was actually a political calculation, as much as it was a public health calculation. I think these two go hand in hand. But we specifically said we're going to focus on naloxone or Narcan, which is the opioid antidote. There are a lot of people who, at that time, may not have acknowledged addiction as the disease that it is, right? They saw it as a moral failing, they saw it as a crime, they saw it as something else. But it was also very hard to say, even for those people, to say, if there's somebody dying in front of you, you shouldn't save their life. So that's what we focused on. We said, we're going to teach everyone in our city about naloxone. We're going to blanket naloxone throughout our city. We're going to get legislation changed, and we did in early 2015, so that as of June of 2015, I became the single prescriber for naloxone across our city, which is now, a lot of people are doing this, but at that time, it was kind of revolutionary. We essentially made Narcan over the counter in 2015. And I wrote a prescription for 620,000 residents in our city. I went to our state legislature. I went to City Hall. I went to all these places in order to have the highest, whatever was the highest visibility. I wanted to teach people how to save a life. And I wanted the mentality, the rhetoric in our city to change from addiction is something that happens to other people to addiction is something that happens to our friends, our colleagues, and you, all of us, can save someone's life just by carrying Narcan with us. And so we did 30,000 trainings in 3 years. Everyday residents in that time period saved over 3,000 lives. We got the police department, police officers to carry Narcan. We eventually started LEAD, Law Enforcement Assisted Diversion, that was modeled after Seattle's program, where individuals caught with small amounts of drugs for subsistence use would be diverted to treatment instead of incarceration. We expanded our drug treatment courts. We started at that time, a first of its kind, 24/7 ER for addiction and mental health, called a stabilization center. We were able to focus on treatment later because we first got the political capital and the buy-in to do the work through our Narcan. And so I say this because I think sometimes people look at public health as just about follow the science, which I believe is necessary. You have to follow the science when you're in public health, but I don't think you would be effective if you don't take into account where people are and meeting them with the political reality of where they are and their thinking to bring them along with you.
It's an excellent segue into my next question, which is about COVID. So you've taken some criticism on social media about some of your views about getting back to normal, right, during the pandemic. And obviously, there are a lot of people who are still, immunocompromised. Young kids can't get vaccinated yet. A lot of people still feel very unprotected and left behind. So I'm wondering if you can explain your argument for returning to normal and what that looks like to you.
Yeah, I want to go back to winter of 2020. Wait, is that correct? Yes, winter of 2020. So December of 2020, when we first had the great news about the vaccines. We were all so excited that they were finally getting distributed. I wrote an op-ed at that time for the Post that specifically said what I think success for the vaccination campaign would look like. I thought success would look like turning COVID from something that is a deadly fear disease that a lot of generally healthy people died from to something that we can live with, to something that still causes some people to become severely ill, but that ideally we're able to treat it more akin to the flu. Ideally, we also have treatments to further reduce the level of harm, but ideally the vaccines protect you well enough that you don't have severe consequences from that. So that was my hope back in December of 2020. Then February, March, April, I wrote a series of columns in 2021. I wrote a series of columns about, at that time, it actually wasn't as clear as it is to me now. And I'm going to say something controversial, and I hope that all of you take this in the spirit that it's been. I would love to engage in this conversation, right? So I'm throwing out there something controversial, but feel free to disagree and challenge me on it. I wrote it at the time, and I think we should have been even more explicit then. Get vaccinated and take off your mask. What I worry about, and actually I wrote an article in February of 2021 when President Biden gave his State of the Union, or at that time it was the joint address to Congress, in February of 2021 with distancing, with masks. I said he shouldn't have worn a mask to that, and this was 2021, because I was worried that if nothing changes for people post-vaccination, that it would actually cause people to further distrust the vaccines. I also, I understand that there are a lot of people who say, well, masks protect others. Masks don't just protect you. And while there is truth to that, right, scientifically there is truth to that, I'm also a realist who looks at where people are as this country. We're a country that is individualistic. We're a country that doesn't have mask wearing in our culture. Do I wish that we were more like East Asian countries? Sure. I mean, it would be great if we had more of this societal, we're in this together, we want to protect one another. That would be ideal. But I believe public health is also about embracing the realities of where we are. And I think we would have gotten much further with the vaccination campaign in the first place if we had had some kind of proof of vaccination and we had said to people, once you're vaccinated, you make the choice about returning back to normal. Some people don't want to, and I fully respect that and embrace that and think that I think there will be a substantial portion of Americans who will always wear masks in perpetuity. I fully respect that. I think if they want to wear masks, if people want people who are immunocompromised, people who are transplant patients, who are family members of cancer patients, I totally understand that going forward, these are individuals who will be masking on planes, for example, or crowded spaces in perpetuity. And that's partly because they see that not only does masking protect against COVID, it protects against the flu, protects against other respiratory. I think that's great that we finally recognize that. I also think in healthcare settings, I frankly don't understand how for so many years in my medical practice, we went from somebody who was ill, their room, into an immunocompromised patient's room, a potentially immunocompromised patient's room, and we're not masking. I think we will be masking in healthcare settings in perpetuity. I think that's all true. But I also think that there are a lot of Americans who equate masks with pandemic restrictions. And they cannot wait for the masks to be rid of for any number of reasons, political and otherwise, or personal and otherwise. And I think we should have embraced that a lot sooner and said, once you're vaccinated, you have done your part, take off your mask, go to bars if you want to. And I think that would have promoted a lot more uptake of our vaccines. So that's my controversial statement. I will also just add here that I personally have changed my own practices, and I can tell you there was one very specific point in time when my own views on risk completely changed. And that point was mid-December of 2021. Not 2020, but 2021. And the reason is I have two little kids, which I'm happy to talk about work-life stuff later on if people want to, but I have a 4-year-old and a 2-year-old. The 2-year-old just turned 2, and so was my own pandemic baby, was born in April of 2020. And for the first part of the pandemic, even as I was writing articles and giving commentary with David on CNN, I was writing all these, even though I was saying other people can move on, I also said, I am one of those people who do not wish to move on because I have 2 kids who are too young to be vaccinated. But 3 things happened in December of 2021. One is Omicron. I saw how much it was spreading, how contagious it was, how much it was spreading even in places with mask mandates and even in places that were mask-wearing cultures. Look at South Korea and Hong Kong. Virtually universal mask wearing with high-quality masks still was spreading. So that told to me that the price we'd have to pay to keep on avoiding Omicron was extremely high. So the calculus was changing in terms of how to avoid this. The second thing was Omicron was less, to an individual, it was less dangerous. Overall, a lot of people were hospitalized, but to an individual, it was less severe than Delta and previous variants. And the third thing that happened in December of 2021 was we received news that there was no vaccine on the horizon for my little kids. And this is still a sore spot, I think, for many of us with families with little kids. And we can talk about that and how unfair it is a separate time. But the way that I saw this was, if we're not going to get our kids vaccinated probably until April, now it's looking more like June, but at that time it looked like April, and also the vaccine, especially against Omicron, may not be that additionally protective, then what are we waiting for? If the price to pay to keep on avoiding COVID was getting higher and higher, and the benefit was not that great, we're not willing to wait anymore. And so that's how our personal risk calculus changed. Although I will say, even back in December of 2020, I was embracing other people changing their risk calculus once they got vaccinated.
Mm-hmm. Okay. Looks like we have time for one more question, and then we'll get to all of your questions. So just briefly, what kind of advice would you give to students? I'm reading the room here, and I'm wondering what you can pass on to this audience.
Yeah. I've been really fortunate to learn from a lot of great mentors, and I'm going to pass to you some of the things that they said to me, and hope that it'll be useful advice in a way that it's been to me over the years, but maybe not even to me at that time. So I'll explain. One thing, the first thing, and I think the most important, one of my mentors is Al Summer, the former dean of the Johns Hopkins Bloomberg School of Public Health, who says that when there's a fork in the road, take it. Now, I think other people like Yogi Berra or other people may have said this too, but similar concept, right? That don't wait. And I can tell you that when I was the health commissioner, I would have a lot of great, recent graduates or fellows or other people coming to work with us. And the people who had the best experiences are the people who jumped in and did whatever they were asked to do without waiting for the perfect opportunity. As in, I think some people might wait and say, well, my dream is to work on HIV/AIDS in East Africa. But what if you have the opportunity to work on HIV/AIDS in Chicago? Don't wait until you have that perfect opportunity. I wrote in Lifelines about my special assistant at the time, who's now doing a lot of other things. But he was finishing law school when he joined my team, and he was supposed to be doing an analysis on public health authority, which actually would be really useful now. I would love to see that paper on the legal underpinnings of what my public health authority was as the city health commissioner. He never got to work on that, and the reason was, as he was about to start, we had the death of Freddie Gray while in police custody in April of 2015. And then we had the unrest that ensued in our city. And I called him up and said, I know you're supposed to study for the bar and supposed to be finishing your exams, but can you start right now and come and join me in the emergency operations center with the mayor and the fire chief and the police commissioner, because I really need your help. And he didn't say, oh, I was supposed to write a paper. You hired me to write a paper. He said, where do I go? Where is the emergency operations center, right? He said, where do I park or whatever? That was his question. And he came, and his first duty was to help me figure out how to get medications to seniors in the city whose pharmacies had burned down and couldn't get access to medicines. Think about how fulfilling that experience was for him. If he had said, oh, I can't start, I'm supposed to be doing a desk job and doing this research, but he said, I'm going to jump in. And so I say this because, again, I think a lot of people might wait for that perfect opportunity, but take the one that you have now. The second is, a mentor of mine also said, as I was at a point, I think at that time I was finishing residency, was looking for my next career or for my next job. My mentor reminded me that you should think of your career as in seasons. And I didn't quite understand that at the time. And it's taken me years to really understand, I think, what she meant at the time. And I think she meant that a lot of times we look at a job in particular as the perfect job. So for me, coming out of residency, I knew I wanted to teach and do research and do some policy work and some public health. And I wanted to find the perfect job that was 25% clinical, 25% teaching, or 25% policy. And I think the idea was, well, maybe that job exists, but can we instead think about the totality of our career and think about, this is the one job you have right now that might be 100% one thing right now. And then your next job is 100% something else. But over the course of your career, all your seasons added together might be that 25% clinical research, et cetera. And that actually helped me take a lot of pressure off, because I didn't have to find this perfect job. It was finding a job that was right for me at the time. So coming out of residency, I was really focused on patient-centered care, working with my mother, coming out of that, and I wanted to do clinical work, and so I took a job that was 75% clinical, 25% research and teaching, then went to 100% or 95% in public health and 5% clinical, and so I think, and then now that I have children, I also really prioritize my kids and being there for them as much as I can to put them to bed at night and dinner and so forth, and that's important to me for that season. And so I think that was helpful. And then the last thing I'll say too is, and I don't think this is something that necessarily someone said to me, but is something that I would definitely impart on everyone else is, I think so often when we look at jobs and careers, we look at the organization that we're working for, the mission of the organization, what we do on a day-to-day basis, and then we look at who are we going to be working with. I think we should flip that and instead ask, who am I going to be working with every day? Mm-hmm. I think that makes the biggest difference. When I think about the jobs I've had that are the best jobs, that I've learned the most, it's because I was working with a mentor that I truly believed in. And it almost didn't matter what organization they were with. I mean, none of my mentors, for example, would have gone to work for Philip Morris International. You know what I mean? Like the mentors I have would be value congruent. And then it doesn't matter what organization they work with or almost what I did. I mean, Fitzhugh I talk about in the book, is a great mentor of mine. And I followed him to different places. And it didn't matter whether he was working in global health in Africa or medical education in California. It didn't matter, because I knew that I believed in him and I would learn from him. And so I would just impart that too, that it's look at the people that you're going to be working with.
Yeah, that's great advice. Okay, so what questions do you all have? I'm gonna start with you, go ahead.
And I'll try to be short in my answers because I was pretty long-winded.
Thanks so much for coming. I'm James, fourth-year student at the college. So I'd love to hear your thoughts about this kind of like life expectancy gap between America and other countries, right? Because we are the wealthiest nation in the world, and we do have like the most advanced hospitals in the world. And I know there's probably like a million different causes, but I'd love to hear your thoughts on like what are like the biggest drivers of that kind of gap.
I'll name two. I usually think in terms of threes, and so by the end I might have a third. I'll name two to begin with. One is access to healthcare, and the other, and more important, is social determinants of health. And so access to health, I mean, I think this is, right, it's pretty common sense. Not everybody has access to healthcare. Lots of people who are uninsured, underinsured, et cetera. I want to focus more on the social determinants of health. That's one of the core aspects in public health, right? Knowing that it's not just about the care that you have access to, it's everything else. So I'll give you an example from Baltimore. It should be, when you look at life expectancy in our city, 20-year gap of life expectancy, depending on the neighborhood that you happen to live in. Then you track why. Well, the number one cause of death in our city, as it is in Chicago, is cardiovascular death, strokes, heart attacks, et cetera. Mm-hmm. Why does that exist? I don't know that the statistics in Chicago, but you look in Baltimore, there are huge disparities in race, huge disparities socioeconomic and geography. Why? So one level deeper, right? One level deeper, you find that 1 in 12 whites in our city live in a food desert without access to fresh fruits and vegetables. 1 in 3 African Americans in our city live in food deserts. And so when I talk to a patient and say to them, please eat healthier, you have diabetes and heart disease. And she says to me, I have to take 2 buses in order to get to a Whole Foods, and then I can't afford the food there. The corner store, the closest thing that comes to a vegetable is an old banana and a bag of chips. What am I doing at the end of the day? And so to me, if we really want to fix this life expectancy gap, it's not just the access to healthcare, it's all these other elements in people's lives.
Mm-hmm. It's similar tale in Chicago. Go ahead.
Hi, thank you for joining us. My name is Jonathan. I'm a first year at the college, and my question to you is, after supporting universal mask mandates, you characterize cloth masks as, and I quote, facial decorations. When did you first realize that cloth masks didn't stop COVID?
I appreciate the question. So 2 parts to this. One is a direct answer in terms of when, is Omicron. That's the short answer is Omicron. Was that when you look at the data, the studies that were done pre-Omicron, so in the middle of the Delta wave, including studies done in schools. And most kids in schools, as you know, are wearing cloth masks. Not all of them. Some are wearing surgical masks, some wearing both. Some older kids are wearing N95s, but most, especially little kids, are wearing cloth masks. actually there were pretty good studies that found that universal masking in schools, including with cloth masks, reduced the number of outbreaks in schools. So I was quite convinced by that, and so was promoting universal masking at that time. Omicron came. And if you're looking at now the states that had mask mandates during Omicron and states that did not, there was really no difference in transmission. And that has to make us think. That has to make us think. I am not saying that we should have never had mask mandates, but rather that we have to be intellectually honest. And I think that there has been some, I don't want to say intellectual dishonesty, but rather I think masks have been equated with something other than what they are on both sides. That one side has equated masks with control, and the other side has equated masks with respect. And I think there has been this narrative of, well, we need to show each other respect by masking with a cloth mask. But I would really like to understand, in this time of Omicron and this more contagious BA2 variant, how much is mask mandates, how much is universal masking really doing? I would have preferred, and this is what I was saying back in December when I made that comment about facial decorations. I wrote a column about it and then talked about it on CNN at the end of December. I really wanted the focus to be not, don't wear a mask ever, right? That was not my point. My point was, we need to be talking about the quality of masks. If we really want to make a difference, and I wrote a column about how we need to look at Austria and Germany and Italy. When they required masks, they were requiring N95 masks. That makes a difference. I don't understand why we're putting so much political capital. I mean, it expends a lot of political capital to do a mask mandate. And if we're expending all this political capital, but not getting much out of it, what are we doing? I think we would get more out of it if we had said, let's give everybody free N95s. And if we're going to do a mask mandate, make it an N95 or equivalent mask mandate. So that's what I was trying to get at here. Not that no one should ever wear masks or that masks don't work, but rather that things have changed since Omicron, and our realities have to adjust accordingly.
What's that?
If there are female students.
Oh, yeah. Let me see. I don't see any raising their hand.
If not, then
Go ahead.
you have no choice.
Thank you. I was really moved by the story you shared at the beginning of the boy who passed of asthma, in part because his grandmother was fearful of taking him to seek medical care. And as I'm sure you know, that's often called like a chilling effect that illegal immigrants or undocumented people face in the U.S. I'm curious, in your roles both as a physician and as a public health administrator, before and during the Trump presidency and before and during the COVID outbreak, how you dealt on a local level with that chilling effect to try to, increase maybe preventative care or increase care that could be given to people who are fearful of immigration services at the hospital setting.
Yeah, it's a terrific question. And actually, your question contains your answer, I think, which is that it has to be done at the local level. I'm not saying that national policy doesn't make a difference or that there is an effect of the Trump administration or whatever. Of course, that makes a big difference. But ultimately, it's the trusted messenger on the local level. And David and I have shared our stories of how working on the local level, you really feel like you're making this big difference in people's lives because it's so immediate. It's also because of the trusted messenger. I mean, it's one thing for us to be issuing a proclamation as the health department even to say, hey, we treat everyone in our clinics regardless of documentation. It's quite another if we have somebody who works in that community to say to people who they work with, who they live with every day, to say, hey, I went into one of these health department clinics to get dental care. No one asked about documentation. Don't worry. No, it's not going to be a problem. You can get medical care free there. That's where I think all the change happens. And that's why I'm such a big proponent of local control and also of the trusted messengers on the local level.
In the blue?
Awesome. Thank you. My name is Daniel Schmidt. I'm a freshman here. I just have a question about some things you said in the past. So on national TV, you said, quote, you have the option to not get vaccinated if you want, but then you can't go out in public. So at this time, 150 million people weren't vaccinated. So you told 150 million people you can't go out in public. Do you still believe that? And if so, why?
I think at that time, so I had written an op-ed. I reference these columns because this is how I think in terms of the views that I'm expressing. And so I was on CNN probably talking about this column that I'd written with a colleague of mine, Sam Wong from Princeton. And the two of us had written this column that was equating the decision to remain unvaccinated with the decision to drink and drive. And specifically, we were making the argument that if you are knowingly, at that point, and by that point, I don't remember exactly when it was, but I think it was fall of 2021. And so it was definitely at a point when vaccines were widely available, right? It would not have been appropriate to say this back in March of 2021 when people were still first getting vaccinated. At that time, vaccines were widely available, and we had also seen the statistics at that time that people who were unvaccinated were many more times more likely to be infected with COVID compared to somebody who was vaccinated. Those statistics have changed. Right now, the statistics are something like between, if you are vaccinated and boosted, you are about 2 to 3 times less likely to become infected with COVID compared to somebody who is unvaccinated. At that time when we wrote the article, I don't remember exactly, but the number was much higher. So you were much more likely to be infected with COVID compared to somebody who was unvaccinated. And I believe we were also just seeing the Delta wave at that time. And so the comment that I was making actually was not saying that people should stay isolated in their homes, but rather that we as a society have to make a decision about how do we protect individuals. And I was looking at the examples of France and Israel and actually many of our cities, including, I believe, Chicago too, but we had seen New York was early on doing this, Seattle, San Francisco, and others requiring proof of vaccination in optional settings, right? Not grocery stores or pharmacies, but if you want to go out to eat in a restaurant, if you want to go to a concert, that you need to show proof of vaccination because that helps to protect other people around you. I think that now the calculus is different. And I had actually interviewed Scott Gottlieb, the former FDA commissioner, for a column of mine. And Scott had said, and we had a nice back and forth for this. I ended up siding against him. It was an interesting way of he said eventually he liked the column, regardless of the fact that at the end, I basically said, here are all of Scott's views and I disagree. But he had made the argument, he was specifically talking about the vaccine mandate at workplaces, the OSHA rule, right, that President Biden initially was issuing for employers with over 100, for over 100 employers. And he said something about how the juice is not worth the squeeze. As in, you can get more people vaccinated, but at what cost? Is it going to bleed over into other things? Like, is it going to make people distrust public health authorities more? Is it going to make childhood immunizations harder to come by? Are religious exemptions going to be used throughout, and then now they're going to be used for all other things too? And I actually think that there is a tipping point, just like for mask mandates. There's a tipping point at which vaccine mandates, the juice becomes not worth the squeeze. And I think that is a difficult, nuanced conversation to have. And I hope it's something that we can have more of, because I think that we need to see all of these interventions, including masking, or mask mandates rather, and vaccine mandates, as having a benefit and a cost. And at some point, the benefit may be worth the cost, but at some other point, it may not.
We have time for one more question in the back. Mm-hmm.
Hi, thank you for being here. I'm Alexandra, I'm a 4th year. I was wondering if you could talk about how you maintain work-life balance. I know you alluded to that earlier, especially for people who are hoping to have careers, and you've had such an incredible career yourself, but also who are hoping to have a family at some point.
I really appreciate the question, and I'm glad that I opened the door to that question too, because I feel like sometimes if I don't say I have 2 little kids, people may not want to ask questions about it, and so thank you for that. I don't have an answer here. I'll just give you some thoughts. One is that I had always thought of work-life balance as something that you make a decision about once, as in choosing a particular job, you decide, oh, this is my work-life balance for this job. I didn't realize until I had kids how it's a constant decision that you make every hour. Of like, do I write this extra piece? In which case, I might miss my school's play. And if I do this, if I do this extra talk, but I'm now going to be flying away from my kids for an extra, it's just this constant juggling act that I don't think I quite understood. A lot of people have said that having a supportive partner really makes a big difference, and that's very true. I would say that for us, frankly, it's been really challenging during COVID. My mother passed away, as you can tell from the earlier story. My father is remarried and lives in Vancouver. My husband's family is all in South Africa, in Johannesburg. And my mother-in-law has been ill and hasn't yet met our 2 kids. Wow. Or she's met the older one, but she hasn't yet to meet, I call her the baby, but she's 2. And my mother-in-law has yet to meet her. And so, but having family so far away also means that we don't have a support network around us. And that's been extremely challenging. I would just say in terms of work-life balance too, that one thing that for me has been helpful is to find something that helps to center me and to literally make time for that and prioritize that. And so I'll end with this, which is kind of this is totally a non sequitur in everything else that we've talked about, although kind of ties back to your first question about asthma. I had severe asthma growing up, right? And so I was deathly afraid of the water and never learned how to swim. Even though I ended up growing up in LA, I just was this thing that I was scared to put my head underwater. It made me feel like I was having an asthma attack, like I couldn't breathe. And so I decided that I was going to learn how to swim last year. And I took, swimming lessons with 6-year-olds, which is a very humbling experience when you do that. But actually I've learned to really love swimming. And for me, making time and carving out time for swimming in my life has been important. So I don't know if that's quite the answer you were expecting for work-life balance, but I think for each of us, finding something like that is just important to prioritize ourselves and our well-being too.
As a former lifeguard and longtime swim instructor, I thank you for doing that. It's very important to learn how to swim. Thank you all so much. Thank you, Dr. Wen, for this conversation. Thank you all for coming. Thank you for inviting us. It's been a real pleasure.